And good morning, everyone, and welcome to Grand Rounds for Internal Medicine. I'm Kim Williams, and it's my online pleasure to introduce our introducer for today's update in portal hypertension given by Dr. Brown from Wayne State. Our introducer will be our vice chair for research and our hepatology researcher extraordinaire, distinguished university scholar and professor of medicine, biochemistry, and molecular genetics, pharmacology, and toxicology, Dr. Matthew Cave. Take it away, Dr. Cave.
Thanks, Kim. So it's my pleasure today to introduce Dr. Kim Brown. And she's going to be talking about really a relevant topic here in terms of updates on portal hypertension. So there were recently some new guidance, a new guidance document issued by the AASLD. I believe it was about a year ago last fall. And I recall the first time I read through this document, I was sitting at our fellows clinic with Craig McLean, and we looked through that document together. And Craig said, "Oh my gosh, I'm doing everything wrong." And uh, I'm not sure that he was, but the point is that there have been significant updates to the management of portal hypertension patients that many in internal medicine might not be aware of. And so Kim is an expert in this area. She recently published a manuscript on that was co-authored by her own Ashwani Singhal. So Dr. Brown did her medical school at Wayne State University, and that was followed by residency and fellowship at Michigan. And she moved to Henry Ford, where she's been since the early to mid 90s, and has really become or has been a national leader for a long time now, really at the society level. And so she's had multiple leadership positions, not only at Wayne State related to transplantation, but leadership positions at the societal level. And she currently serves as our Liver Society AASLD Foundation chair. She's also had leadership roles in UNOS and the OPTN, greater than 100 publications, very prolific in terms of industry-sponsored studies. Kim, I think you listed 8 pages of them. Some of those we've participated in as well, and a very distinguished lecturer. And we're delighted to have you here today. We hope that we could have brought you in person, but there were some changes that I'm not going to get into that were not from us or you that kind of prevented that from happening. But anyway, welcome virtually, and I look forward to your talk.
Thank you so much. Thank you. Thank you, Matt. Thank you, Dr. Williams. Thank you, Dr. McLean, for the invitation to speak today. And as Dr. Cave said, we're going to talk about updates in portal hypertension, but really from, I think, a medical resident standpoint, right? So these are patients that you manage every day. So what is portal hypertension? Well, this obviously occurs in patients with cirrhosis. It really is a reflection of elevated portal pressures. And this results from both a combination of increased blood flow into the portal vein and increased resistance to outflow through the damaged liver. And this is an important distinction as we talk about some of the therapeutics that we utilize. So again, increased resistance. You see the architectural changes due to the fibrous tissue formation. You get vasoconstriction within the liver due to formation of endogenous nitrous oxide. But you also see increased blood flow through splanchnic arterial vasodilation, and both of these work together to increase portal pressures. And as portal pressures increase, you have complications, right? You have shunting, which can result in hepatic encephalopathy. You get increased salt and water retention in the form of ascites and lower extremity edema. And you can have the formation of varices, which can result in bleeding. So we'll talk about each of those. But there are additional causes of portal hypertension. Cirrhosis is clearly the most common cause that we see. The site of increased resistance within the cirrhotic liver is at the sinusoidal level, but there are other causes of portal hypertension, and they're classified according to the site of increased resistance. So you can see prehepatic, you may have a portal vein thrombus, for example, which it can increase portal pressures as well. Pre-sinusoidal, we see that in schistosomiasis, although I've never seen a case of schistosomiasis. Sinusoidal, of course, is cirrhosis, and then post-sinusoidal and post-hepatic with either veno-occlusive disease, which you can see in patients who have undergone chemotherapy primarily, or patients who have a hypercoagulable state, in which case you may see something like Budd-Chiari. So this is what cirrhosis looks like. I put this picture up because the word cirrhosis is used in many ways, but it actually means the fourth stage of scarring. It's a histologic diagnosis, and in order for a pathologist to call cirrhosis, you have to see these broad, here in this slide, the blue bands of fibrous tissue that completely surround islands of hepatocytes. So that's really what cirrhosis is. We use it in a multitude of ways. It doesn't tell me how sick a patient is. It doesn't tell me how well the patient is, but it does place the patient at further risk. And when we see how this operates, and I draw this picture every time I see a patient, this is the portal system of blood, right? You see drainage of all the abdominal organs, goes through this large portal vein, goes through the liver, has to filter through the liver, and then go back to the heart. And you can imagine that in a patient with cirrhosis, right? You're trying to increase blood flow through a fibrous piece of tissue. And this will obviously increase the pressures, the resistance. I liken it to a garden hose where you have water flowing through the hose and then you crimp the hose. And what's that water going to do? It's going to go into any low pressure system it can find. And those connections occur over to the spleen. That's why the spleen enlarges up through the top of the stomach, bottom of the esophagus, creating varices. So again, it's this resistance to blood flow through the cirrhotic liver that increases these portal pressures. And there are a lot of complications of portal hypertension. We're going to talk about a few of those, but certainly it can affect the kidney in terms of hepatorenal syndrome. We're not going to talk about cirrhotic cardiomyopathy, but this is a critically important issue, particularly in your patients who are in the intensive care unit in terms of how they can manage and handle volume status. Splanchnic vasodilation occurs within the gut. Obviously, we see ascites in our patient population, hepatic encephalopathy, and then the pulmonary complications that can be specifically associated with liver disease include hepatopulmonary syndrome, but also portopulmonary hypertension. So this is a slide that kind of tells me or helps me help patients understand that this is a progressive process over time. So on the left, you see the normal liver, and obviously injury to the liver can occur in a multitude of different forms: alcohol, metabolic disease, immune disease, metabolic disorders. But as that injury pattern continues, you start to see, in some cases, fat inflammation or inflammation in general. You get a deposition of fibrous tissue, and you get the progressive fibrosis that we see over time. But superimposed on this, you see host and environmental factors, right? If I have autoimmune hepatitis, but I also drink a lot of alcohol, you have environmental factors, host and factors that are going to play a role. If you have genetics that don't work well with alcohol, you may have more progressive process over time. So again, how fast this develops depends on a multitude of different things. But eventually, over time, you can develop cirrhosis, and eventually that places a patient at risk of liver failure, portal hypertension, liver cancer, etc. So we define early stages of liver damage as compensated. You can have cirrhosis but be compensated, but as portal hypertension progresses, you become decompensated. And why is it important that we distinguish between the two or try to delay the progression to decompensation? So here's a survival curve. On the top, you see the survival in all patients with cirrhosis, and on the bottom, you see the survival curve in a patient who has become decompensated. And you can see that as decompensation occurs, the mortality risk vastly increases. And this is why in patients who have decompensation, these are the patients we're thinking toward transplantation. Because again, continued management of that patient from a medical standpoint may not allow long-term survival given their significant increase in mortality risk. So I'm going to give you a few definitions because these are the definitions that we now bandy about and you need to understand. So what is a hepatic venous pressure gradient? Well, again, you have to take the boards at some point, and some of this may be on the board. So just try to stick these numbers in your head. Portal hypertension is actually defined as hepatic venous pressure gradient greater than or equal to 5. But clinically significant portal hypertension, and this is kind of a newer term that we've started to define to try to help us understand who may be at marked increased risk of further complications. This is defined as a hepatic venous pressure gradient of greater than or equal to 10 millimeters of mercury. So, advanced chronic liver disease, this is a patient who is likely to have or close to having cirrhosis, so advanced fibrosis, F3 and F4. Compensated advanced chronic liver disease, again, now we're starting to define this not endoscopically, but by liver stiffness measures. I'm sure you guys have a FibroScan or a transient elastography at your institution. And a liver stiffness measure by transient elastography, less than 10, really rules out the fact that the patient may have advanced chronic liver disease. But if you have a value of 15 or greater, then it is likely that you do have advanced chronic liver disease, but yet you remain compensated in many cases. Compensation really means that you have no complications of portal hypertension, and those are included below: overt ascites, variceal hemorrhage, or overt encephalopathy. And clinically significant portal hypertension, hepatic venous pressure gradient greater than 10 millimeters of mercury, or you can also use transient elastography. And this is a transient elastography, a KPA of 25 or more. So, in the new guidelines, authors have looked to try to better stratify and help us understand the progressive nature of portal hypertension. You can see on the left the stages of chronic liver disease and the patients as you go to the right who have no cirrhosis, compensated cirrhosis, and then decompensated cirrhosis. And you can see as you move to the right, the histologic diagnosis worsens, right? So patients have increasing fibrosis, but then they also start to have clinical events of decompensation. The hemodynamic features you can see there, again, clinically significant portal hypertension. This really places the patient with compensated cirrhosis at increased risk. So that's the person you need to identify looking toward trying to modify portal pressures for that individual to prevent them moving further to the right. But again, on the bottom, you can see as you move to the right, the mortality risk significantly increases. On the bottom, we've now started to better understand the ability that we can look at portal hypertension in a non-invasive manner using transient elastography. So this is, we call it the rule of fives. This is really stems from what we call the Bravino criteria, which is really a way to non-invasively assess portal hypertension. You can see on the left, liver stiffness measures, the KPAs, less than 10, identifies the patient who likely has no evidence of advanced chronic liver disease. Those patients who have a higher or increasing score, but still less than 15, are likely compensated, but without clinically significant portal hypertension. And then as you move to higher KPA measurements, you can see those patients have clinically significant portal hypertension. And we can use these to identify the patients at risk and the patients that we may
have anyone
treat.
UPS system still.
So the consequences of portal hypertension that you may see either in the clinic or in the hospital include varices with presentation of variceal bleeding. You may see patients presenting with shortness of breath and pleural effusion. You may see kidney dysfunction. We often see patients admitted with ascites, or you may see patients presenting with mental status changes, encephalopathy, or at earlier stages, tremor or sleep disturbance. So the complications of cirrhosis really result from a combination of both portal hypertension and or liver insufficiency. So if you look at the complications such as variceal hemorrhage or ascites, these are primarily related to the elevated portal pressures in terms of formation and progression. But when we talk about encephalopathy, for example, this is a combination not only of portal hypertension and shunting, but also of elements of liver insufficiency. But once we develop these with respect to ascites, for example, it places the patient at further risk of complications such as spontaneous bacterial peritonitis or SBP or hepatorenal syndrome, which we'll talk about. So the treatment goals in a patient who has portal hypertension, what are your goals? Well, first, your goal is to reduce portal pressures. If you can, and we'll talk about means by which we can do this, treating the underlying liver disease is critically important because, again, the resistance to blood flow through the liver is in part due to inflammation, and that can be precipitated by steatosis, for example. So if you have a patient with fatty liver, if you have a patient with autoimmune liver disease, and the patient loses weight or the patient gets treated with prednisone, you can reduce the inflammation within the liver, and that can actually improve portal pressures to a degree. But certainly, at the end of the day, you need to identify and treat the complications that we see with portal hypertension. So let's start with varices. So esophageal gastric varices are present in about half of the patients that you will see with cirrhosis. But it is important for us to understand that the presence correlates with the severity of liver disease. So if you look at patients who are Child-Pugh A, about 40% of patients are reported to have varices. But as you progress to further stages, Child C, over 80% of those patients are likely to have varices. In patients who have cirrhosis and who do not have varices, it is said that they progress and develop them at a rate of about 8% per year. And in patients who have small varices, they can go on to develop larger varices, again at a similar rate, about 8% per year. So this is another number to stick in your head because it may be on the boards. This is the threshold portal pressure necessary for varices to form. So if you look at this graph, these are patients and measuring portal pressures. On the left, you see those pressures in patients who had the presence of varices, and on the right, you see the pressures in patients who did not have varices. And what you can see is that all of the patients who had varices that could be observed had portal pressures greater than or equal to 12. Now, if you look on the right, you can see that some of the patients who didn't have varices also had a portal pressure of 12. So what this means is that a threshold pressure of 12 is necessary for varices to form, but it doesn't result always in patients to have varices. So you have to have an elevated pressure for varices to form, but not all patients who have a portal pressure of 12 will have varices detected. And if you look over time, there's a progressive nature to this. So again, on the left, you can see a patient's esophagus with no varices. This is a clean esophagus. In the middle, you start to see those blue columns. Those are varices. They're small varices. We used to grade varices 1, 2, 3, and 4. Now we call them small or large and look at results and treatment in that way. And on the right, you can see large varices, those large blue columns that are extending down the length of the esophagus. And when we look again at Child-Pugh score, you can see not just the prevalence of esophageal varices increasing as liver disease advances, but the size of the varices. So if you look again, you can see the different hatch marks are large, medium, and small varices. And you can see as you move to the right, patients who are Child C have a much higher chance of having varices, almost 80%. And you can see the increasing number of those patients who have both medium and large varices. So varices increase as liver disease advances, and the size of those varices increase as well. So one of the questions that you may think is, okay, I have a patient with cirrhosis. Can I prevent them from developing portal hypertension? Can I prevent them from developing varices? So this was a multi-center randomized placebo-controlled trial. This was using timolol, which is a non-selective beta blocker, versus placebo in patients. Beta blockers, it did not prevent the development of varices and were associated with a higher rate of serious adverse events. And so you will see in the recommendations from AASLD that in patients without varices, treatment, prospective or elective treatment with non-selective beta blockers is actually not recommended. But then the question becomes, can you decrease the risk of clinical decompensation in patients who have clinically significant portal hypertension and cirrhosis? And in this study, the primary endpoint here was decompensation or death. So you have patients who were randomized. There were 100 patients randomized to beta blockers and 101 patients randomized to placebo. And you can see out to 60 months, the placebo group, this is the cumulative incidence of the primary endpoint. And again, the primary endpoint was decompensation or death. You can see a much higher incidence of decompensation and death in the patients who were treated with placebo as those compared with the patients who were treated with beta blockers, suggesting a protective effect in a patient population treated with beta blockers. Similarly, if you look at the reduction in hepatic venous pressure gradient, so if you are able to achieve a reduction in portal pressures, you actually do see a reduced risk of variceal bleeding. So this was a study looking at rebleeding rates in patients with varices, and you can see across the bottom, in patients who had a hepatic venous pressure gradient that was reduced to less than 12, no patient had rebleeding. In patients who had a reduction in their gradient greater than 20% from baseline, again, higher than if they had a pressure gradient less than 12, but it was about 7 to 13%. But most importantly, on the right is the patient population who had no change in hepatic venous portal pressure gradients. There was a significant risk of bleeding in that patient. So again, looking at the efficacy of reducing portal pressures, you can see benefit in terms of decompensation and death, but you can also see significant effects in terms of rebleeding rates in patients who have underlying varices. So traditionally, when I was training, we used propranolol. Many studies have suggested that carvedilol is superior. And again, further evidence that carvedilol, in particular, as a non-selective beta blocker, can help us in our patient population with clinically significant portal hypertension in terms of reducing overall risk. So this was a competing risk meta-analysis. There were 4 randomized controlled trials here. And the important part of this study is that individual patient data was used. There were 352 patients who were enrolled who had compensated cirrhosis, and half of them were treated with carvedilol, and the other half were controls. And look to the right. So if you look at the control group is in the dark blue and the carvedilol group is in the hatched light blue. And the top graph shows you the incidence of decompensation in patients who were treated with carvedilol versus those in the control group. And you can see a significant reduction in decompensation in the carvedilol treated group. And on the bottom, you see similar results in terms of death. So again, further evidence that treating a patient with clinically significant portal hypertension with non-selective beta blockers is beneficial to them over time. So then we have a patient who shows up in your probably your ICU with a variceal hemorrhage. And what are some of the ways that we can manage or alter portal pressures, which are contributing to the bleeding, in the setting that you're seeing the patient? So you all know that a patient comes in with variceal bleeding. Probably the first thing you do is you call GI, but you start the patient on octreotide. Octreotide works by causing splanchnic vasoconstriction. So remember back to that first slide that I showed you, that resistance to blood flow and portal pressures is a result not only of architectural changes in the liver, but also portal blood flow. So here you have a medication that restricts splanchnic blood flow, and as a result, you get a reduction in blood flow to the liver. In part, it also works by reducing nitrous oxide synthesis. This was a meta-analysis looking at 13 randomized studies because we've used lots of vasoconstrictors in the past, including vasopressin, terlipressin. We've used things like sclerotherapy alone, balloon tapenade. This was a study looking at variceal bleeding risk in a patient, rebleeding risk in a patient population, again, receiving octreotide versus many of those alternatives. And you can see a significant effect of octreotide in terms of reducing recurrent variceal bleeding. More urgently, patients may present to you and they have failed other therapies, and so TIPS can be considered. If you don't know what a TIPS is, that's what it looks like on the top right. I always describe it to a patient population as a Chinese finger ladder, if you've ever used those. On the bottom, you can see how it works. It's placed percutaneously through the vessels, and you're essentially connecting the portal venous system to the hepatic venous system. That's essentially what you're doing, creating a highway for some of the blood to go directly through the liver without filtering, and as a result, you can reduce portal pressures. And we really use it as a rescue therapy for patients who have failed endoscopic or pharmacologic therapy for esophageal varices, and we also use it as a first-line treatment for gastric varices. So there are other means by which to manage gastric varices, but traditionally TIPS has been one of the first things that we have used. How does it work? Well, 90% of the time you'll get hemostasis, so it works very well because you're reducing portal pressures, but it doesn't alter long-term survival. So this is not a long-term solution for a patient who you're trying to manage. So you have to save them in the short run, but you have to understand that you're not really altering long-term survival with the TIPS. The goal is obviously to reduce the portal pressure to less than 12, and complications, as you know, can include hepatic encephalopathy because you're increasing shunting through that liver, but also liver decompensation. It's important to understand that in you or me, we have two blood supplies into the liver, both portal and arterial, and we can pretty much survive on either one of them. But in a patient who has advanced liver disease, they become very dependent on that dual blood supply. And so when you're diverting some of that blood supply away from the liver, you can actually cause decompensation. And we use general measures. I use a bilirubin of 4 as a general measure. Others have used MELD score. The reason I use bilirubin is that MELD often depends more on creatinine than anything else, and so we have to understand overall risk to the patient who has advanced liver disease. So again, general management, when you have a patient who comes in with acute variceal bleed, you're going to resuscitate the patient. We're going to talk about antibiotics that you are suggested to give patients who have upper GI bleeding. We're going to try to correct the coagulopathy. Critically important, we're going to talk about this, is transfusion goals for the patient. And then I think more controversial is whether you give that patient lactulose or not, whether there's any benefit in a patient who comes in strictly with a variceal bleed. Specific therapy, we've talked about octreotide, early endoscopic therapy, band ligation, which is why you call the GI fellow, and then certainly shunt therapy, including TIPS. We won't talk about surgical shunts because those are now rarely used. So what about transfusion? Well, when I was training, I was taught to transfuse in a patient to a hemoglobin of 10. And the reason for that is that in my teaching, it was better to bleed from a hemoglobin of 10 than a hemoglobin of 6, right, in terms of complications, cardiovascular complications. But many studies have now looked at survival according to the transfusion strategy. So here on the right, we have a restrictive strategy where the goal is to keep the hemoglobin near 7, and a liberal strategy, which is in this case 9 or above. And what you can look here on the right right is, and this is all upper GI bleeding, right? In a patient population with cirrhosis. But again, if you look at the overall survival, it's actually better in the patient population where you restrict the transfusions to a goal of 7 as opposed to 9 or higher. And if you look further at the subpopulation of patients with varices, again, on the left, you're looking at the percentage of patients who failed treatment. And you can see that the percentage of patients who failed treatment was less, significantly less in the restricted strategy group as compared to the liberal strategy group. And if you look on the right, you can look at 6-week survival, and it was actually higher in the patient population where you restricted the overall transfusion and limited it to a hemoglobin target of 7 as compared to a more liberal strategy. Now, again, this was 6-week survival. This doesn't, we haven't shown that it extends to 1 year or 3-year survival. But again, why might this be? Well, if you think about how portal hypertension works, right? If you are over transfusing a patient, if you are over resuscitating a patient, you are increasing their volume status. You are potentially further worsening their portal hypertension. So again, cautious transfusion is critically important in this patient population. What about antibiotics? I tell my fellows that the final common pathway for all good cirrhotics to die is infection. We see that commonly. Prophylactic antibiotics in patients with cirrhosis with GI hemorrhage have been shown by meta-analysis to reduce infection, but also improve survival and reduce recurrent hemorrhage. And why is that? Part of it is that there is implication that LPS or certain byproducts of bacteria actually can worsen and alter portal pressures as well. And so again, prophylactic antibiotics in a patient population, and this can include cephalosporins, quinolones, augmentin, vancomycin, all have been looked at, can actually improve outcomes in our patient population who are bleeding. What about patients who have had a variceal hemorrhage? And again, now looking at recurrence of hemorrhage. And again, you can see on the top, and again, you have to read this appropriately. This is the percentage of patients who are free from recurrent hemorrhage. So higher graph is better. Okay, and you can see that the patient population receiving prophylactic antibiotics had less rebleeding. They had more often, they were free of rebleeding than patients who did not receive antibiotics. And you can see that most of this effect is very early on. So again, it is one of the reasons why we recommend that when a patient comes in with variceal bleeding, that they receive prophylactic antibiotics as part of their treatment. And then again, you've called the GI fellow. If you just needed to give octreotide, you wouldn't need to call anybody else. But again, endoscopic therapy is critically important in controlling acute variceal hemorrhage. And in fact, when you combine drug therapy with octreotide with endoscopic therapy, whether it be sclerotherapy or banding, this is more effective than endoscopic therapy alone in achieving early hemostasis. And so you can see these multiple trials here combining octreotide and looking at favoring endoscopic and drug therapy versus endoscopic therapy alone. And so again, combination therapy is what we recommend for patients with acute variceal hemorrhage. So here is a summary from one of the summaries of the summary, I guess, is what we would call it. The Portal Hypertension Guidelines. Dr. Brown and I and others tried to interpret the new guidelines for others. And this is one, I think, of the important algorithms that I think you should have in mind as you see these patients. Patients who have compensated cirrhosis with no evidence of clinically significant portal hypertension. Again, based on those studies that I showed you, non-selective beta blockers are not recommended. But you clearly want to focus on lifestyle modifications, treatment of the underlying disease, again, other ways that we can improve overall outcome. On the right, you can see those patients who have clinically significant portal hypertension, and then we look at those with and without varices. Both of those patients receive non-selective beta blockers, right? Because you're trying to reduce the risk of progressive disease. And again, in patients who are intolerant to non-selective beta blockers, that is when endoscopic evaluation can be helpful. So let's turn now to ascites. You can see this is a pie diagram of all the things that can cause ascites. Whenever a patient has a belly full of fluid, they always get sent to the hepatologist. It doesn't matter what it's due to, but they make you figure it out. But you can see that the bulk of the patients who will present to you, in fact, the etiology is ascites. But one of the patients that I commonly see who are sent to me are those patients with heart failure as well. So again, that would be a post-sinusoidal, right? You get again, increased pressures and potentially ascites formation from the fact that the right heart doesn't work. So what is the pathogenesis of ascites? Well, it's really dependent on three things primarily. On the left, you can see portal hypertension. We've talked about that. You get increased sinusoidal pressure, you get increased lymph formation, you get ascites formation, but you also get splanchnic vasodilation. And this can result in arterial underfilling. You get activation as a result of multiple vasoconstrictors and antidiuretic factors. This can lead to sodium retention, plasma volume expansion, further worsening ascites. But you can also get dilutional hyponatremia. You can get renal hypoperfusion leading to hepatorenal syndrome. And then on the right, we talked a little bit about bacterial translocation, again, systemic inflammation that can further worsen hepatorenal syndrome, but also lead to spontaneous infections, including SBP. So when you see a patient in the hospital, who gets a diagnostic paracentesis? If you're seeing them in the hospital, the answer is everyone. So the indications for a diagnostic paracentesis include anyone with new onset ascites to try to determine etiology, anyone who is admitted to the hospital, anyone who has signs or symptoms of SBP. Don't presume that you can figure out whether a patient has SBP. I would say the majority of patients that I diagnose with SBP actually have no abdominal pain. Mostly they have nausea. Renal dysfunction is important because oftentimes SBP is a precipitant of renal dysfunction, and any patient who has unexplained encephalopathy, because infection is always high on the list. Contraindications, I think there are none. I often get pushback because the platelet count is 50 or the INR is 2. Very nice study done looking at the safety of paracentesis in a patient who had INR greater than 1.5, platelet counts less than 50. There was a 1% complication rate. So again, I think safe to do. So how do we evaluate this? And again, this is always on the internal medicine boards, how to figure out what the ascites is due to, but a diagnostic paracentesis, you're going to look at a serum ascites albumin gradient, and you're going to look at the protein. That's going to help you for the majority of patients that you see. So in a patient who has an elevated serum ascites albumin gradient greater than 1.1, you have two choices. You have portal hypertension and you have post-sinusoidal. So you either have a blockage in the venous side, or you have more commonly cardiac dysfunction. And it's the protein that's going to help you decide that. Patients who have a high SAG and a low protein, that's a patient with portal hypertension. Patients who have a high SAG and high protein, that's a patient where you're going to want to do further imaging. You're going to want to Doppler their abdominal vessels to look for hepatic venous outflow issues, and you're going to want to do a cardiac exam with an echo. Patients who have a SAG less than 1.1, that's the patient who more likely has peritoneal disease. Again, you're going to want to look for cytology. Tuberculosis I've diagnosed in this way. And again, oftentimes these are more challenging to diagnose and oftentimes lead to laparoscopy and even peritoneal biopsy. How do we manage uncomplicated ascites? Well, we restrict sodium. And again, I try to help patients understand if they're eating a normal American diet, it's about 7,000 milligrams of salt a day. If they simply don't add salt to the table, it's about 4,000 milligrams of salt a day. So they really have to pay attention if they're going to get down to 2,000 milligrams a day. I often see fellows and residents fluid restricting patients. There is absolutely no need to do that unless you're trying to manage hyponatremia. What do you start with? Well, you start with a ratio of 5:2, right? Spironolactone 100, furosemide 40, and again, you're going to monitor response in that patient over time. So how soon should you monitor them? Well, in the hospital setting, the patient, you're not going to see a response on day one. And so it is important that you don't change the diuretic dose every day. You need to give it time. In fact, spironolactone has actually quite a very long half-life. Although we dose it sometimes BID, it has a very long half-life. So you need to leave the patient room to actually know whether they're going to respond. How do you monitor that? Well, you're looking for a kilogram in the first week and about 2 kilograms per week thereafter. If a patient is diuresing more quickly, and I would say a half a kilogram per day in patients with no edema, very hard to diurese a patient in the absence of lower extremity edema. Those patients who have ascites alone, you need to be cautious. But if you are looking for dietary indiscretion, most patients will actually tell you. I have patients who tell me they drink olive juice, for example, clearly not understanding how much salt is in that, but looking at a spot urine sodium potassium ratio, if it's greater than 1, the patient should be losing weight, and if they're not, they likely have dietary noncompliance. What about refractory ascites? This occurs in about 10% of patients with cirrhosis. 80% are considered diuretic intractable, and that means that you're working toward therapeutic doses of diuretics, but before you get to a place where the patient is actually improving, they're developing diuretic-induced complications, renal insufficiency, hyponatremia, etc. But you also have patients with diuretic-resistant ascites. This is said to be about 20%. I think it's probably lower than that in my patient population, but this is a patient where you've maximized their diuretic therapy, which would be considered 400 milligrams of spironolactone a day, 160 milligrams of furosemide, and they're still not responding. So what options do we have? Well, large volume paracentesis is often what we go to. TIPS is another consideration. By definition, a large volume paracentesis is 5 liters or more. So again, you have a patient in your hospital. If you are taking more than 5 liters, that is considered large volume. Why is albumin used? So you can see that it is recommended that if you do a large volume paracentesis, you are giving albumin. The reason to give albumin is to decrease the risk of post-paracentesis circulatory dysfunction. When they've done studies in patients with large volume paracentesis where they swan the patient, you get very acute changes in intravascular volume when those shifts occur, and this can result in renal impairment, hepatorenal syndrome, again, delusional hyponatremia, even encephalopathy, and even worsening terms of mortality risk. How do you replace albumin? Well, it is recommended 6 to 8 grams of albumin per liter of ascites. So after the 5th liter, you're likely giving 40 grams, and after the 8th liter, 64 grams. What about early tips? So we've thought about tips in control of ascites. Again, we have to think about the risks to tips in a patient, but there is some evidence that in patients who have refractory ascites, where you choose to place a tips early as opposed to continuing large volume paracentesis, that in fact survival may be improved. And why might that be? Well, with large volume paracentesis, you're simply removing fluid, right? You're simply managing the complication. But when you put a TIPS in, you're actually reducing portal pressures, and that may be in part the survival advantage. So again, something to think about in a patient population that has really, truly refractory ascites. So you will also see SBP in the patients who are admitted by diagnosis. Again, this will be on your boards. It's a PMN count of 250 or more without another intra-abdominal source of infection. What are the risk factors? Well, the risk factor is if you've ever had it before, you are at increased risk of getting it again, but also very low fluid protein within the acidic fluid, and also current variceal bleed. So again, general measures, you're going to infuse albumin. Again, albumin has been shown to be beneficial in patients who have SBP. Specifically, you're going to treat with antibiotics. We often use ceftriaxone, but again, this can be guided if you have a patient where the culture turns positive, certainly guide it in that way. Secondary prophylaxis is important. If you've had a patient hospitalized for SBP, again, that's a risk factor for recurrent infection. And so it is recommended that long-term antibiotics be given to try to decrease the risk of recurrent SBP. Ciprofloxacin or trimethoprim, sulfamethoxazole have been used. And then are there patients where we might primary prophylax then? Patients who have very low protein in their acidic fluid, or patients who have renal dysfunction, or patients who have a very high Child's Pugh score and elevated bilirubin. Again, patients with the most advanced disease, again, they may benefit from primary prophylaxis.
You just
So
like plug in my laptop once.
we're going to change now to the diagnosis of HRS-AKI. So this occurs in a patient population with ascites. The diagnosis of AKI is now according to the criteria, which involves an increase in serum creatinine of more than or equal to 0.3 milligrams per deciliter from the baseline. So in order to figure that out, you need to know what the patient's baseline is. Patients have no response after 2 consecutive days of withdrawing diuretics and giving albumin, so fluid resuscitation. They can't have shock or use of nephrotoxic drugs, and no signs of structural kidney injury as well. So again, this is a functional problem as opposed to a structural problem in the kidney. So this is a very nice algorithm that was published looking at the diagnosis of AKI-HRS. So again, you have a patient who's been admitted to your hospital. You see that their creatinine has risen by 0.3 or more. You're going to assess them like any other patient. Maybe they have a UTI. Maybe they have obstruction or ATN. If they have that, you're going to treat that specifically, right? But if there are no other etiologies found, and the creatinine has increased to 0.3 or more, you're going to stage that patient, right? They can have AKI stage 1 very early, so no doubling from baseline, or AKI stage 2 or 3, where they have had a doubling of their baseline creatinine. In both cases, you're going to manage their risk factors, right? You're going to withdraw their diuretics, you're going to give them albumin, you're going to monitor them. If they improve, then you continue with your therapy. But if they don't, then they meet the criteria for HRS, and then you're going to move into some kind of further therapy, such as a vasoconstrictor. So vasoconstrictors, norepinephrine or terlipressin in combination with albumin do improve kidney function. So this has been shown in 20 to 80% of patients. Therapy with a vasoconstrictor can be continued up to day 14 or until the creatinine returns to baseline. And in the terlipressin trial, that the average was about 6 days. Midodrine and octreotide have been used like water at our institution, likely yours as well, but there is clearly lower efficacy than terlipressin, and it is not FDA approved. Terlipressin now is FDA approved. The important difference between norepi and terlipressin is it can be administered on the floor, and it is currently recommended by guidance from AASLD as well as ACG. So this is one study that actually did compare midodrine and octreotide plus albumin versus terlipressin plus albumin in the treatment of hepatorenal syndrome. Complete response in this trial was defined as a decrease in serum creatinine to less than 1.5. You can see on the right the rates of response were significantly higher in patients who received terlipressin as compared to those who received midodrine and octreotide. So again, this can be given on the floor and currently again recommended by guidance. And then finally, hepatic encephalopathy. This is a brain dysfunction caused both by liver insufficiency and/or portosystemic shunting. Remember that. There's a wide spectrum of neurologic or psychiatric abnormalities. Not everybody comes to you in coma. The prevalence of overt encephalopathy at time of cirrhosis diagnosis is about 10 to 14%, higher if the patient is decompensated and higher if the patient has undergone TIPS. Up to 40% of patients with cirrhosis will experience HE at some point in their disease. So if you have a patient in your clinic with cirrhosis, it is important to tell them to watch out for this, right? I've had patients who have come to me, their family members are like, nobody ever told us this could happen. We had them go see a psychiatrist. The patient was running around the house trying to hit me with a broom. They don't understand this. They need to understand that there's risk and what to do if it occurs. Minimal or covert HE, and we're not going to talk about that, but that can occur in up to 80% of patients with cirrhosis. It is not what you and I can detect clinically, typically not the patient who shows up at your hospital, but again, requires very specific testing to identify, but clearly affects a significant portion of patients with cirrhosis. So there are many precipitating factors for overt encephalopathy, infections, GI bleeding, diuretic overdose, constipation if they stop stooling, etc. So thinking about what may have precipitated an episode is important when a patient is hospitalized. There is always a differential diagnosis. Does the patient have out of control blood sugar? Is the patient using alcohol? Does the patient have a positive tox screen? Do they have an infectious complication? Have they just fallen? Do they have a stroke? Or do they have an intracranial bleed? So again, not just assuming that this is HE related to cirrhosis, but making sure that you've looked for other etiologies as well. It is important, I think, to classify HE, and this is a nice classification scheme that was proposed by AASLD, the type being on the left, whether a patient has acute liver failure, so no evidence of cirrhosis, but acute liver injury. B is the patient who has portosystemic shunting, so somebody who may have an intra-abdominal shunt unrelated to cirrhosis, and then, of course, C is cirrhosis. The grade there, minimal HE, and then 1, 2, 3, and 4, these are the West Haven criteria. Again, covert or disease that you may not or someone may not really appreciate in a patient, typically minimal HE, which requires very specific diagnostics, or very early HE, and then overt HE. As defined, grade 2 would be patient who is lethargic, moderate confusion. 3 would be patient who is markedly confused but yet arousable. And of course, 4 would be that patient with coma. How do we treat it? Well, it's important. Every episode should be treated. Alternative causes need to be investigated. And if there is a precipitating factor, opioid use, alcohol use, etc., they should be removed. Treatment is lactulose as the first choice, and again, rifaximin has been shown as an effective add-on therapy for the prevention of recurrence. Other therapies such as branched-chain amino acids, IV LOLA, have been utilized. I don't routinely utilize them because most patients respond to lactulose and rifaximin. Other antibiotics, neomycin in particular, really minimal evidence for efficacy, and neomycin in particular can cause issues. The last thing I'll leave you with is that typically if I ask residents who dies first, the patient who's bleeding from varices, the patient who has refractory ascites, or the patient with HE, look at these results. Patients who have HE should not be ignored because the overall survival rate in that patient really mirrors that of a patient who has active or recent variceal bleeding. So again, in your patient population who has one of these complications, consideration and referral for possible transplant should be done. So in summary, Portal hypertension really has significant impact on both morbidity and mortality in patients with cirrhosis. The management of clinical consequences of portal hypertension do not change overall survival, though, in patients who have cirrhosis. So you're managing the consequences, you're not altering survival. Identifying patients with cirrhosis and monitoring those patients, looking for evidence of decompensation is important to allow you to better manage that patient and follow that patient up. And it is very important to consider liver transplantation in appropriate patients while you're directing efforts toward the reduction in portal pressures and managing the clinical sequelae of the disease. So I'll stop there and thank you very much for your attention.
Thank you, Dr. Brown. That was outstanding. So I know Dr. Cave, Dr. McLean are here, but either of you want to kick off with a first question for Dr. Brown?
Sure. Sure, and I'd like to add, Dr. Brown, I've seen a lot of talks on portal hypertension, but this was absolutely outstanding and one of the best. So I think our GI fellows ought to get 5 to 10 GI board questions right from attending this talk, and the internal medicine residents ought to get a couple, depending on how many they get asked. So I do have a question, and it's a little bit maybe more nuanced, but in hepatology and we use a lot of albumin. The residents and fellows are very impressed, compared to other services. And I recall at the liver meeting last year, and I think maybe this was stemming from some of the terlipressin data, which showed some harm when there was pulmonary edema and fluid overload. And it sounded like maybe as a specialty, we might be using too much albumin, but I don't know how much is the right amount. And I was wondering if you had any knowledge or thoughts on that. It's okay if you don't. It's a little bit.
I have a lot of thoughts on that. It is really interesting because historically, when you look at a lot of the literature in the past, the level of albumin in a patient with cirrhosis has related in part to overall morbidity, mortality, right? And so it gives you the idea that more is better, that if you get an albumin to a higher level, patients are going to somehow have a survival advantage or do well. The clinical trial that actually looked at that, where the target level of albumin, there was a target level of albumin. If you look at this, first of all, there was no improvement in survival in that patient population. But the second thing is, if you look at the complications were on the respiratory side. So with terlipressin, when you look at that data critically, the patient population who was highest at risk was the patient who got large, it's not just the albumin, it's large volumes of albumin, right? So many of those patients were transferred into that clinical trial. They had received albumin, but yet as part of the clinical trial, they had to get a prescribed amount of albumin. So we have created an algorithm and a dot phrase within our system that albumin is not mandatory. You have to look at the patient, right? You have to make sure that they are volume expanded and that they are not volume restricted at the time that you give terlipressin. But again, it's going to vary from patient to patient. If you have a patient who's volume overloaded, you're not going to just randomly give them albumin. So yes, albumin is beneficial, but we need to be thoughtful about how we're using it. A lot of times we're using it for volume expansion. And if that's the reason you're using it, again, you have to be cautious.
Thank you. Questions from the audience?
Yes, actually, I was going to say, if anybody wants to unmute and ask a question, please do. Or if you want to put it in the chat area. There were a couple of questions. One is in our chat area. One is from Dr. Dawn Castor. She's an associate professor in our nephrology division. She wants to know, can you comment on MAP goal in HRS? Also, while terlipressin is superior to midodrine, I'm knowing butchering these. Are there studies comparing to norepinephrine?
Yeah, so very good questions. The studies that have really been done have been revolved mostly around safety and efficacy and where you can give. So in our patient population, I can't get a patient with a creatinine of 2.2 into my intensive care unit. So for me to use norepi, for example, which is used or can be used in our intensive care unit, we can't really do it. So in my opinion, the advantage to terlipressin is primarily as to where you can give the medication, because many of these patients, the earlier you treat their HRS, the better. And if they're early, they're on the floor. And so giving terlipressin on the floor, I think, is important. So we don't strive specifically for a specific MAP. What I will tell you is that when patients come to the hospital, I will typically reduce and try to withdraw their beta blockers if that's affecting their blood pressure. Many patients who have very advanced liver disease obviously have relative hypotension, and that's not helping kidney perfusion either. So in a patient population who comes typically with HRS, I'm not striving for a specific MAP, but I am ensuring that they're volume resuscitated and withdrawing diuretics, and also, and in most cases, reducing or withdrawing beta blockers.
Okay. And Dr. McLean, it looks like I see you're here. Well,
Yeah.
you have a
Yeah.
question?
So,
Go ahead.
Kim, great talk. It seems like one of the things that's changed dramatically in the guidelines, and certainly since we trained, we used to do endoscopy all the time looking for portal hypertension. And now it seems like everything has shifted to fiber scans. So can you comment and reemphasize that a little bit?
Yeah, no, I think one of the nicest things that has happened, I think, are the development of Bravino criteria and our ability to, for the most part, utilize non-invasive measurements to guide beta blockers, but also endoscopic therapy. You know, I was taught, I'm sure you were taught, if you had a patient with cirrhosis, you did an endoscopy. You and I both knew that many patients sitting in front of you were never going to have varices based on what you knew about them clinically. And so exposing them to the risk of endoscopy was not particularly helpful. So I rely heavily on the Bravino. I mean, we have transient elastography. Many places don't. Obviously, if they don't, you would still need to look for large varices or a presence of varices with endoscopy. But I think the non-invasive criteria are the biggest change that we've seen, I think, with respect to portal hypertension diagnosis.
Great talk.
And just a couple of more questions from the chat. One is from Dr. Stanley Levinson, one of our retired researchers. He wants to know, there was always a question about whether or not ammonia caused HE or amino acids. Said, of course, ammonia is hard to measure accurately. What is the current view?
Well, that's a great question. I could give you an entire talk on my feelings about ammonia. I have been a hepatologist for 32 years, and I have never measured an ammonia level, okay? In large part because it's fraught with problems. It can be elevated, and if the patient in front of you is clearly thinking, what are you going to do? It can be normal, and the patient in front of you is confused, what are you going to do? It doesn't really guide your therapy. The one exception, I think, is in patients who are in the ICU setting, patients who have acute liver injury, elevations above 200 have shown some prognostic indication. But again, I think encephalopathy is the development, and the pathophysiology is likely multifactorial. I don't think ammonia is the cause, the specific cause, but it is likely a marker and something that's elevated. But I don't measure it because it doesn't really guide me in how I treat the patient clinically.
All right, and one last question, and this is from Dr. Brianna Trishon. She's from our palliative medicine division, and she says, "I'm curious about your institution's relationship with palliative care. We are often only involved once a patient is deemed to no longer transplant candidate or pushing towards comfort care, and think we could probably get on board sooner."
Yeah. You know what? I think that's a really great point. I think probably anybody, much like cancer, right? Anybody who has advanced liver disease that's decompensated probably should have palliative care as part of their clinical care team. Again, we're so striving toward end results, transplantation, et cetera, but we are involving them more and more, particularly in patients who have alcohol use disorder. who may not meet criteria for transplantation, and we realize risk is very, very high in that patient population. That's the patient more so, but also the older patient who may not do well with transplantation. Again, are they getting to palliative care too late? Probably still.